Good afternoon, everyone, and welcome back. My name is Laura Conrad, and I am the department's legislative director. I'm happy to be with you today and happy to introduce our final plenary session presentation by Dr. Stacy Walton. Dr. Walton has recently retired from Kaiser Permanente as a clinical pediatrician, serving in the roles of both diversity champion and communications consultant. Today, Dr. Walton is going to be sharing with us the topic of the bias of first impressions. So, Dr. Walton, welcome, and please begin your presentation.
Full morning, and there's been a lot of new information shared with participants. I'm sure you have a lot of new thoughts, new things you want to try, skills that you're going to try on. I'm sure there were things that were said around this topic of bias that this topic of psychostimulant, the topics in the symposium that have left some emotions with many of you, some feelings that may be trapped in your body, thoughts that are all over the place. So I want to start this presentation with an exercise of centering all of us, bringing us all in the space so that we can let everything else go for this next 45 minutes. I would like you to be able to really focus in on this PSA, this public service announcement around recognizing and reducing implicit bias in our professional work and also in our personal lives. And so if you feel comfortable, get comfortable in your chair with your feet firmly planted on the floor. Take notice of your body, how it's feeling, whether you're feeling tense, whether you're relaxed. If you feel comfortable, close your eyes, and we're going to take about 6 intentional breaths. And what this will do is switch you from one set of nervous system to a different set of nervous system, from that sort of hyper-stimulated nervous system to one that is more relaxed and calm. And when we are relaxed and calm, we're more receptive to hearing new information and new ideas. And so as we breathe intentionally, I'm going to implant a few thoughts with all of you. And as you take in a deep breath with your eyes closed, I want to implant this thought. Number 1, you all do honorable work. And you may repeat, if you so desire, I do honorable work. And with the next breath, I share with you your work makes a huge difference in many people's lives. And if you're so inclined, I'd like you to repeat as you're breathing in and relaxed breathing out, my work affects many people's lives. And the final thought I'd like to impart with you is this. Your work has saved a life today. And if you feel inclined, I'd like you to repeat, my work has saved a life today. Take a deep breath in and let it out. Welcome to the space. I'm very, very, very honored to be asked to be here. I'd like to start with my story, a story. About 23 years ago, I was laying on a hospital gurney in an operating room having a C-section. It was my second. My baby girl was about to be born. And as I lay there in deep rapture, deep excitement, lots of anxiety. I heard my OB say, she's being born. I heard her cry. My OB said she has 10 fingers and 10 toes. A smile started to cross my face. The pediatrician wrapped my daughter in a blanket and took her to the warming bed, and my husband scooted away from my side and went over to the warming bed. And I waited with anticipation to get to see my daughter. They were going to give me a quick peek before they took her to the nursery. My husband walked over with my daughter. She was all bundled up. I, with anticipation, turned and looked at her. And in that moment, instead of feeling this rush of love and rapture and excitement, I completely closed down. Let me rewind a little bit. I was at that time at the peak of what I thought my professional and personal career. I had finished my training. I'd been in California. I had an undergraduate degree in cultural anthropology. I'd gone on to New York City and got a medical degree. I got my pediatric training close to your home at Children's Hospital of Philadelphia. And I had returned home to Denver, Colorado as a director of a pediatric and adolescent clinic at a community health center literally 3 blocks away from my grandmother's house. I had arrived. I was teaching at the University of Colorado Medical School to medical students and residents around, at that time we were calling it cultural competence. My area of expertise was cross-cultural communication. I was wedding cultural anthropology with medicine. I was in a nerdy high around what I got the opportunity to teach. And with that work, I prided myself with a very large ability of tolerance, of acceptance of difference, whether it was ability, disability, class, age, race, ethnicity, disease. I had this skill of being able to walk in someone else's shoes and be very accepting. That was the context in which I looked at my daughter and closed down. You see, my daughter, born of 2 African American parents, had, when I looked at her face, she had blonde hair, blue eyes, and white skin. And I completely closed down. This conversation that we're having about implicit bias has the power to undermine the most important personal relationships in your life, as well as those important, critical professional relationships that you have in your life. If you remember only one thing in this talk today, remember this, that we all have implicit bias. Implicit bias isn't unique to one group of people or to one perspective. Our brains are wired for bias. Today we're going to talk about the brain and how it's wired. And then I'm going to end the presentation and talking about strategies for circumventing the way our brain is set up. Quick definition of implicit bias, and this is really, really important definition because we have to distinguish between those biases that are obvious to us, that we walk around in, versus those that are hidden in our deepest psyche, but have influence on our day-to-day behavior. Implicit bias is an error in decision-making which stems from a prejudice that developed from an association based on stereotypes that you are not aware of. And that's the key. An example of an explicit bias that I have, that I own up to, is a bias, around tattoos. As an adolescent physician, I see a lot of tattoos, and especially about 10 years ago, 15 years ago, maybe even 20. I had a lot of young people coming into the office with tattoos, and my explicit bias, my conscious bias, was there was something defective about these teens, that they were headed in the wrong direction, that those tattoos represented some lack of internal efficacy. And the day that bias was thrown directly in my face was when a young lady who literally was tattooed from forehead to foot, I'm exaggerating a little bit, and all those explicit biases were bubbling up. All of my prejudgment about her was bubbling up. She said, "Dr. Walton, can you fill out my form? I have a form that needs to be filled out." "A form for what?" "Well, a form for college." I said, "Oh, you're going to college?" She said, "Yeah, I'm going to Harvard." I said, "Oh, and what are you studying?" She said, "Psychology." And I thought, that's great. She can come back and study me. But in that moment, I recognized that my biases against tattoos were bubbling up through the whole visit. I had her pegged. I had her figured out. And she, with one request, filling out a form for college, she circumvented all of those biases. Quick definitions: a bias in and of itself is not negative or positive. I can have a bias towards the color purple versus the color green. No significant influence on you, my patients, my clients. But I could also have a bias like the one that I talked to, a bias around tattoos. And literally, that behavior, those thoughts could have, if I weren't self-reflective, could have had negative implications on my interactions and my nonverbal communication with this young lady. Like I said before, biases can be implicit, unconscious, explicit, conscious. Prejudice. What is prejudice? Prejudice is just in the name. Prejudgment is when we make a prejudgment about a person, about a group, about an idea, prior to getting to know that person, that group, and that idea intimately. What is a stereotype? A stereotype is when I add that prejudgment to an individual who happens to be part of that group that I've formed all these prejudgments or prejudices about. So our brains are wired for bias. Our brains are wired for prejudice. Our brains are wired for stereotyping. Keep in mind, however, that we don't see things as they are. We don't see reality as it is. We see reality. We see things as we are. I don't know where this quote comes from, but it's right on the money. It's about perspective. My lived life experience, the lens from which I look out into the world, determines what I'm going to see. So perspective is our brains are constantly creating meaning of our world. And my meaning is going to be different from your meaning. Your meaning is going to be different from your colleague's meaning. And his or her meaning is going to be different from their client. This is this idea of perspective. And I just want to reinforce that idea of perspective, because when we think about how each and every one of us is a unique human being who's had a unique lived life experience, that means our perspectives are unique. There has never been a Stacy in the past. There's only me. There won't be another Stacy in the future. And so when you find yourself in a situation where someone else's perspective is just not in alignment with yours, that is so confusing to you, throw yourself into a state of wonder. I wonder what brought that person to this place. I wonder what gives them that unusual perspective. I wonder, because their lived life experience, whatever that has been, has brought them to that moment. And the more that you get into a place of wonder, as opposed to, what's the opposite, right? The opposite is a place of prejudgment. The opposite is a place of assumptions. The opposite is a place of stereotyping. So when you find yourself with someone or a group of people or even an idea that goes so out of alignment with who you are and what you think about perspective, think of lived life experiences, think about how can I be in wonder. I don't have time for this exercise. Email me. So our brains, what is this about? Our brains are always trying to find meaning with whatever it sees. Illusions, how do we manage illusions? Remember that most of us are familiar with that picture of the vase, that some people see the vase, some people see the picture of two faces facing each other. If you don't know what I'm talking about, just Google face and vase and illusions, and that picture will pop up. This is another exercise in illusions that I'm going to skip because of time. But it's the same idea. Our brains make meaning out of what the stimulus that's coming in. And that stimulus can be interpreted in many different ways. Our brains also create neural connection through association. Think about infants. Think about how they learn, young children, how they learn. We teach them colors by taking the color and saying the word. And every time we see that color in an object, we point to it and we say, what color is that? And so the child has this association between the color green and the word green, or the picture of green. An example of that is, what do you think of when I say the word boot? What came to mind for you? I was born in Denver, Colorado. I grew up wearing these Claire boots. I wore them in the winter. I wore them hiking. I wore them when I went skiing. I wore them to school, to the chagrin of my mother. I wore these big clunky boots everywhere. So whenever I hear the word boot, for some people they think, well, when I hear the word boot, this is what comes to mind. I'm sure that's not the same for everyone. If I were born and raised in London, if I heard the word boot, what would I see or think of? I'd think of the luggage carrier in a car. That's a boot. My point is to just hone in, or just to push that point around perspective, that our brains are wired for making meaning, and we make meaning with association. Something didn't translate. Associations, that first bar should say something like early childhood experiences, just meaning as we're growing, as we're learning, those early socializations, lots of associations are happening during our early childhood, whether it's learning our languages, learning early knowledge. That second box is supposed to say socialization. And what that is about is that as we move from childhood, let me step back a little bit. When we're born into a world that's already created. There are institutions and traditions and big issues that are already, big socialized issues that are already in place. Many of them are what I teach about, you know, the caste systems, the racial hierarchies, the gender hierarchies, the class hierarchies, religious tolerance. Many things are already in place. And early childhood learning happens within the family. And so the family helps that child bring priority to different associations, brings meaning to the world that the child was born into. And as we, the third that third box, lived life experiences, that's talking about as we move towards adulthood, we create more associations. We may unlearn some that came with us early in life because they don't fit us anymore, and we may relearn new ones depending on lived life experiences as we move through young adulthood associations. So back to the brain. Our brains are wired for survival. You probably hear people say all the time, we don't use 10% of our brain. Well, that's not really true. We don't use 90% of our brain, and that's kind of true and not true. It's not true in the sense that we use 100% of our brain 100% of the time. It's just only 10% is for our thinking brain. Like that 90% is our unconscious brain, that part of our brain that has been wired in particular for survival. That part of the brain that that's wired for survival. And most of those associations that are happening as stimulus comes in are so that you can survive. How many of you have gotten in your car after work, gotten home and said to yourself, oh my gosh, how did that just happen? Your brain was in unconscious survival mode to get you home. And why is this important to this conversation? This is important to this conversation because that survivalist part of your brain is what we call fast brain. What the Nobel Prize winning economist Kahneman said, our brain processes, there are two main categories, the fast and the slow. The fast are those unconscious associations that get us through the day, that take those millions of bits of data that come in every second and associate them in ways that this is important, that's not important, we'll file this in a file, we'll let that go. We'll let that particular stimulus bubble up into the human's conscious brain, because that's a conscious bit of data they need to hear. But most of it is unconscious, most of it's happening at very, very fast rate. And then there's that slow part of your brain, that thinking part of your brain that is thoughtful and intentional and reasoning. Let me give you a quick example. It's not coming up very well, but this is a multiplication problem. It says 56 times 37. For most of us, we move into a slower part of the brain to answer that question. If that multiplication question had been 1 times 1, hearing that, most of us, it's an instantaneous answer. 1 times 1 is 1. But 56 times 37, I can attest for myself, is a slow and intentional process. In fact, I'm a visual learner, so I'm going to take out a piece of paper and a pencil and start writing things down. There are some of us who have unconscious processes for these advanced mathematical equations. We call those savants, and there are probably some of you out in the audience today. Why is that important? It's important when we think about the evolution of the brain. The brain evolved. These are very general concepts. I'm not a neurobiologist, and any neurobiologists in the room, forgive me for being so basic, but this is a PSA, public service announcement. So in the evolution of our brain, evolved into 3 parts. The first part was that reptilian brain, fight, flight, freeze, the survival part of the brain where decisions have to be made fast in order to survive the possibility of being eaten by some big, huge creature. And then our brain developed this other region, the limbic region, which is more associated with emotion and empathy and social interaction, and really created that ability for us to be have those unique characteristics that people call human, our ability to be social and live in groups and form societies, et cetera, et cetera. And then the higher functioning of the brain, the cortex, the prefrontal cortex, that's where that's the thinking powerhouse of the brain, the prefrontal cortex. Why am I bringing this up? I'm bringing this up in this discussion around bias because bias, especially implicit bias, is more apt to, what's that expression? Well, more apt to show up when we are using or we are engaged in more survival brain activity. And what do I mean by that? There's this concept of the brain state management model where there are three major brain states. There's our reptilian lower brain state, and in contrast, our higher brain state. And during the day, each and every one of us are moving in and out of these different brain states all day long. When we are in our threat stress brain state, when we are anxious, when we are fearful, when we are super busy, we are in this state where we're more likely to be making decisions and exhibiting behavior that is unconscious. And that is why understanding brain states is so important. When you are in that threat stress brain state, your choices are unconscious, your perception is really closed, your self-awareness is down. And so in those moments where you're interacting with a client or giving a talk, and if you are in a fearful, anxious state, you're less likely to be mindful, perceptive, self-aware, creative, innovative. Your choices are less likely to be conscious. And so one of the things that in this conversation that's important to get some grasp on is that in any given moment of the day, you can be in any of these brain states, and there are ways to recognize those brain states. The cues are three. There are physical cues, emotional cues, and thinking cues. When you are in fight or flight, your body is tense, your heart rate is up, your respiratory rate is up. Your emotional cues are fear, anxiety, frustration at the highest degrees. Your thinking cues are perseverating over things like, I can't do it, this isn't happening, I'm going to die, this is the worst thing that's happened. And it's sort of these repetitive thoughts. The flip is when you're in your higher brain state, your physical cues are that you're relaxed, you're calm, your heart rate is down. Your emotional cues is that you have a lot of awareness of your emotions, you have empathy, you feel connected to the other person. Your thinking cues are creative, they're expansive, you're able to hold different opinions, different thoughts, contrasting thoughts all at the same time. And so as professionals, our desire is to be in our higher brain state as much as possible when we're interacting with clients, when we're interacting with our professional colleagues. And I would argue being in your higher brain state is where you want to be most of the time. So that's great. I can say you should be in your higher brain state all day long. Well, how does one do that? This slide was a slide about neuroplasticity, which I will summarize. Basically, the idea is that your brain is neuroplastic. You're capable at any given time to unlearn and relearn. That neuroplasticity is stronger when you're younger than when you're older. And this particular video, which I would love everyone, I'll make sure that this information gets out to everyone to check it out. It's called Neuroplasticity with someone named Destin with Smarter Every Day, who learns how to ride a backward bicycle. And with the point of the video is that with persistence, dedication, repetition, and time, he's able to learn how to ride a backwards bicycle. It takes him 8 months. His elementary age son, it takes his son 2 weeks to learn how to ride a backward bicycle. But the ultimate point of that video is just to stress to all of you that these unconscious biases that we hold, we can relearn. We can, once we recognize them, we can change them. And so how do we do that? Here are some of our strategies. I'm going to talk about the IAT, this implicit association test. I'm going to talk about mindfulness. I'm going to briefly mention brain states management again. I'm going to emphasize the importance of our early childhood experiences. I'm going to talk about intergroup interaction, and I'm going to advocate for diverse and inclusive teams as strategies for reducing our biases. The Harvard Implicit Association Test. What the heck is that? Some of you may have taken it before. If not, I would add that to my to-do list. The Harvard Implicit Association Test is actually a test that you can take online. It's private, where you can get insight into some of your implicit biases. Remember, your implicit biases are those that you're not aware of. Why would this be important? The example I like to give is the example of fat shaming. In adolescent medicine, in American medicine, there are a lot of patients who are overweight. And as quiet as it's kept, there is a lot of prejudice and a lot of stereotyping that happens with people who are overweight. Just ask someone who's overweight in your life if they've experienced any of this, and they'll ask you to break out a bottle of wine and sit you down for a few hours. And so one of the things that happens in adolescent medicine is the studies show that pediatricians, like myself, because of our prejudice and stereotypes, we are treating our overweight teens in such a way that they're walking away from the experience shamed, invalidated. Their chief complaints that have real health consequences are being ignored because we become preoccupied with their weight. And so there is this bias that's creating increased, confounding health and mental health issues for our overweight teen patients. As a physician, as a clinician, as a healthcare provider, my first principle is to do no harm. So that particular bias is causing harm, and that's just one of hundreds. The Harvard Implicit Association Test basically is a test that you can take online. It has taken into account the fact that some of our brain processes are very, very fast. It associates pictures with words on the screen, and with your fingers you make associations and you take this test. At the end, there's a Likert scale that says things like you are more likely to identify with X. On the other end of the scale is you're least likely to identify with X. And in the middle is you're neutral about whatever the issue is. The different categories that you can explore are categories around addiction, weight, race, politics, class, gender, sexual orientation. I mean, there's just lists and lists of themes that are addressed in the Harvard Implicit Association Test. I would say take the test. Think about those areas in your life where you may have some struggles with your clients. Think about those areas in your life where you know a colleague is having trouble, or your organization is having trouble reaching out to a certain subgroup or certain subpopulation. Take the test. What's beautiful about one caveat is we know that we tend to think more highly of ourselves in testing. we pre-test, we anticipate scoring higher than we usually do in tests like this. So one caveat is if you don't get the answer you're expecting, basically if you're finding implicit biases in places that you were not expecting, it's not the test. Sit with the results and use it as a guide for improvement. That's the Harvard Implicit Association. How can you use it? In an organization, you can say there's a client group that you're having difficulty with outreach. Get together as a group and say, hey, let's do the implicit test around poor folks. Let's do the implicit test around, I'm sorry, I might just had a blank, around a real religious intolerance. Come together, share the results, brainstorm about how as a group you can work on some of these biases. Do the test alone, do this on your own. There are several tests in the Harvard Implicit Association that I intentionally do yearly to see where I'm going to score, because in between that time I'm actually doing work to uproot, unlearn biases and rewire my brain. And it's kind of cool to see improvement. It's really cool to see improvement. Mindfulness, becoming aware of your thoughts. It's so important to be mindful, because we, in any given moment, hour, day, thousands of thoughts are skimming through your mind. And becoming aware of some of those thoughts, sometimes you'll be really surprised at what's floating by. And if you can learn that skill of mindfulness, the next thing is that you can begin to interrupt those thoughts and create counter narratives. Practitioners in cognitive behavioral therapy talk about tracking. That's what it is, tracking those thoughts that are not useful for you, thoughts that are detrimental to your mental health, tracking them. Oh, there it popped up again, and having in your toolbox, in your pocket, are those counter narratives. What's a good example for that? For me, as a clinician, as an African American woman, I will acknowledge that I have prejudgments and stereotypes towards certain Asian populations. I'm aware of it. I know what the childhood life experiences were that set those associations up for me. I know what lived life experiences have reinforced those associations, but I'm constantly aware of the counter narratives that are more real than my stereotypes or my prejudices. So when I'm about to walk into a patient's room and the last name is Chang, I breathe and I start with my counter narratives. Oh, it's the Chang family. Oh, Lisa is the cutest kid. The last time they were here, we talked about her ballet recital. I can't wait to hear about their new baby that's coming. Do you hear what I'm doing? It's like I'm making sure that the thoughts that I'm having in that moment reinforce, affirm what I know is true, not only about the Chang family, but about Asian Americans that are part of my life. So tracking and having counter narratives that are there and available for you at any given moment is a very powerful mindfulness technique. Other mindfulness techniques that you can use that may not seem as direct, but in the overall picture, strengthen that part of your brain that can turn on mindfulness in the moment, are, of course, meditation. Meditation, journaling, walking in nature, creating quiet environments, yoga. I could go on. The list is pages long, right? Exercising. But adding mindfulness to your professional skill set will make you a better clinician. No question. We talked a little bit about brain states and how you manage those. Mindfulness is a wonderful way, sort of in general, long-term, sort of creating a foundation, being more mindful. But in the moment, let's say you're feeling anxious, fearful, fretful, and you have a patient you got to see in 5 minutes. Close the door of your office and breathe. Take 2 to 3 minutes of intentional breathing. That in and of itself will switch you from a sympathetic surge to a parasympathetic sympathetic surge. It'll switch you from excreting cortisol throughout your body to excreting endorphins and oxytocin. You know, those are the hormones of connection, empathy, and love. You know, oxytocin, yeah. So you can literally change your physical body, your mindset, the physical sensations in your body, as well as your feelings, by breathing. It's extremely powerful, the breath. I'm going to skip this because of time. Well, not skip it, but I talked a little bit about the different brain states and how you can move through. Exploring early childhood experiences, I can't emphasize this enough, as one of the ways to mitigate implicit bias. Because remember, a lot of those associations that happened, they happened early on. I have a picture of a wheelchair to emphasize a point. Most of us, by the time we're in our 70s, I think I got that statistic right. Let me redo that statistic. Most of us, by the time we're in our late adulthood, 70% of us have experienced either transient or permanent disability. And despite that huge number of people who have experienced disability, disabled people are invisible to us. They're invisible. And when I say that, what I'm saying is when you look at our policies and our behavior towards and our inability to provide equity in the workplace and in our social spaces for people who have who have particular disabilities, it's clear that we're not comfortable naming and participating in disability advocacy. Well, where does that come from? One example I love to give is how we treat disability with our children. Young children, 3, 4, 5 years old, are in a constant state of wonder. Well, what is that, Mommy? What does that mean? What is that? How? When? Where? I mean, to the point where parents or adults around them are pulling out their hair, right? So you walk into a store with your 4-year-old, and he begins to point at this man who's in a chair that has wheels and is rolling through the store at 50 miles an hour. And your son says, "Oh my, what is that? Look at that chair, it has wheels. Look at what that guy is doing. Why is he doing that? Oh, that is so, can I have one of those?" Your child is in a state of wonder. And 99% of parents, what do? 99% of adults that are with that child, what do? The child is rushing towards the chair, the person in the chair. The parent grabs the child's arm, pulls them back, and yells at the kid, "Don't do that again. Never, never, never do that." And most of the time, that's the end of the conversation. So that child doesn't get a conversation about ability, disability, not getting into someone else, respecting other people's privacy or respecting their space. All the child gets is a early childhood experience of shame and making a mistake around a wheelchair. And that gets buried deep. When I do workshops around early childhood experiences, we draw pictures. I ask my participants to draw pictures of their first experience with disability. And then we sit in a circle and we discuss them. And then we have work around journaling, etc., to really go deep around those early childhood associations. And if you're doing work that involves working with people who have challenges that are noticeable and those that are not noticeable, these kinds of these exercises are so important. And I would argue that if you're in the world of addiction, that this is a crucial, if you haven't done it already, which many of you may have already done this kind of work already, get involved in exploring your early childhood experiences around addiction, health and disease around addiction. It will make you a superior clinician. Intergroup interaction, The bottom line is the more that you interact with someone who's not part of your obvious group, the more likely you are to take them out of that tribe of quote-unquote other and bring them into your tribe. Dispelling myths and biases and associations that are just not real. So intergroup interaction is one way to mitigate biases. I call that making friends across difference. Advocate for diverse teams. So if you're working on projects together, advocate for diversity. Because what happens, the research is out there. If you have a homogeneous group, you'll get the work done. But if you have a diverse group, you'll get the work done, but at a much, much, much higher level. The actual working environment might be a little bit more of a struggle for everyone. It may not be as comfortable, but in the process, the level of creativity and innovation and effectiveness just improves exponentially. And at the same time, in relationship to this conversation, that's an intergroup interaction that's creating counter narratives towards biases, and that's mitigating or decreasing and reducing implicit biases, unrecognized biases. And that, having said that, when you are increasing diversity within your organization, within your working group, you have to remember that diversity without inclusion is not real diversity, because no one should ever sit on the bench. Everyone should play. And for everyone to play, it requires the group, the organization, to recognize that everyone has their own lived life experience, their own perspective. They're going to come to the party dressed differently. And if we can embrace that difference and ask everyone to dance, right, then the party is enhanced. The work is enhanced. The quality of our work improves. So in summary, well, first of all, this is me 23 years ago with my absolutely beautiful daughter, Nia. What did I do after that fateful, numbing day? Well, what I did was I got in touch with these unconscious biases around white skin, blonde hair, and blue eyes. As an academic, I went to workshops and trainings, read books, reread books that I had read before, talked to colleagues, had heart-to-heart conversations with relatives and extended family. And I recognized that if I didn't get in touch with this bias, if I didn't lift it up, unlearn it, and relearn something different, that I would have unconscious behaviors towards my daughter that would be detrimental to her growth, her self-esteem, and her ability to walk in a world that on the surface for many people is very confusing. And with that, I thank you for your time, and I leave a little bit of time for questions. Thank you very much.
Okay, this is Laura again, and we do have a few minutes. If anybody would like to jot down a question, we have a couple minutes that we could take one or two. Okay, I don't see anybody typing. Oh wait, here we go. Now I see some. Question on what books would you recommend on this topic, Dr. Walton?
Ooh, there are lots. Let's see, where would I start? If you like sort of social reads, I'd recommend Blink by Malcolm Gladwell. If you want something a little more technical that really goes into the brain states model, I'd recommend Casey and Robinson. They wrote a book called The Neuroscience of Inclusion, New Skills for New Times. The book that goes into the detail about the Harvard implicit bias text is Banaji and Greenwald, Blind Spot. There's so many more. What I will do is I'm sending my references to the central person, and I'll make sure that my whole reference list for this presentation, actually let me just for this presentation is shared with everyone. Yeah.
Okay, we'll take just one more question. How do you recommend supporting families of addicted individuals regarding stigma?
So this is from the family's perspective. I think it's really the same conversation in terms of counter narratives. So I think, not being a clinician who's doing that directly, what comes to mind is the whole concept of counter narratives. Recognizing that we all have different perspectives, recognizing that the stigma is part of how the brain handles a lot of data. So I guess helping those families understand that the brain does this, that we all do it, that counter narratives of those stigmas, just because you're hearing this out in the world, just because you're interacting with people who have these beliefs about you, it's important not to internalize them and to have your counter narratives. The other thing I believe very strongly about is this isn't about you. This is about behaviors. So those stigmas are around about behaviors, not about you as an individual. I don't know if that's helpful, but that's how I think about it.
Okay, I know there are some other questions, so we will make sure that you get responses to those in the next few days. And at this time, I want to thank you, Dr. Walton, for this fabulous presentation today. I know you've given us a lot to think about, and I know myself, I'm going to go back and go over this one more time to really absorb everything that you've shared with us today. We do thank you for your participating in this symposium. And now I would like to turn this over to Kim Coleman for some closing remarks.
Thank you, Laura. I'd like to also thank everyone who made this first day of the symposium a success. The presenters, the panelists, the moderators, the technical support staff, and all of the attendees. As many faces as there are on the symposium camera, there are triple the amount of faces behind the scenes making this all happen. So thank you to everyone. I truly appreciate everyone's time and patience and participation. Tomorrow we will begin at 8 a.m. Please make note of the time because it is a half hour earlier than today's presentation. We look forward to having all of you come back again tomorrow. Until then, stay safe. We are officially adjourned for the day. Thank you.